I am 8. My name is Avalab Aguila, and I am one of the people that have OI.
And I'm here with Alap, who is just coming for his infusion treatment. We do a lot of research on osteogenesis imperfecta, and like we give medical treatment, we assess what is the results of this treatment, we develop new treatments. And so people like Alap, they can participate in the studies that try to make the bone stronger and prevent fractures from happening.
I do have a broken bone right now on my back. So it is pretty out right now.
How many fractures you had, do you know?
I haven't counted.
You haven't counted, so then it's many fractures.
Yes.
And you can tell them a bit about
That actually featured Dr. Frank Rausch, who will be speaking later during today's session. But up next, I want to introduce a OIF Board of Directors member, Jacinta White. Jacinta, thank you so much.
Thanks, Michael. Good afternoon, everybody, and wherever you are in the world, sometimes it's morning, evening, and nighttime, so wherever you are, welcome. My name is Jacinta White. As Michael says, I'm a proud OIF board member, and I'm also the president of the Canadian Osteogenesis Imperfecta Society. So I'm delighted to be part of this conference on both levels. This afternoon, I want to welcome you to the pediatric health session. As a parent with a child with OI, it is a challenging time for us as we try and navigate the world of OI with our children. So this afternoon's session is very much designed to give you information, give you access to experts and an expert panel to ask the questions that are foremost in your mind. Today's session is broken into 3 main components, and I'll introduce each. And followed by those 3 sessions, we have an expert panel for a question and answer session. So there's lots of time, as Michael said, to cover any questions that you have. Finally, I just think that, as Michael said, it's really wonderful to acknowledge the Shriners Hospital for Children in Montreal, Canada, a long association and contribution to the OI community globally, and ongoing support and a go-level sponsor for this conference. So we would be lost without Dr. Rausch and the team in Montreal. So without further ado, just talking of Dr. Rausch, he will be leading off the afternoon with the first session. The first session is a medical overview of OI, led by Dr. Frank Rausch, and just so that you have some sense of his capabilities and his experience with OI. He is a professor of pediatrics and a clinician scientist at the Shriners Hospital in Montreal, Canada. He's a member of the and in his work, he has identified new genetic causes of brittle bone disorders and has assessed the long-term effects of bisphosphonate treatments in children with osteogenesis imperfecta. So he is our first speaker, and he will be followed then by Dr. Jean Ferrazone, who will be talking about the orthopedic concerns of OI. And again, another eminent participant, Dr. Ferrazone, is a pediatric orthopedic surgeon at the DuPont Hospital for Children in Delaware. She is a co-director of the Multidisciplinary Osteogenesis Imperfecta Program and is a member of the Limb Lengthening and Reconstruction Society and serves on the faculty of the OIF OI Tele Echo Series. Finally, our third session is one that is very everyday life. This is about the social and emotional topics of OI, and this is led and presented by Dr. Kara Ayres, an ex-member of the OIF board, so it's lovely to see you again, and a phenomenal sort of background for her in terms of her life experience. She's an assistant professor and associate director of the University of Cincinnati Center of Excellence in Development Disabilities. She's earned a PhD in clinical psychology from Nova Southeastern University. Her areas of interest and research include disability policy, parenting with a disability, self-advocacy, foundation of youth with disabilities and disability identity. She's also conducted research. She's very much a part of the OI community, and of course has OI herself. So really a life experience firsthand from Cara. So anyway, nice to see you again. Following the three presenters, we will open for a QA session, as Michael has said, and we have another group of eminent physicians joining us for that panel. And these are the best of the best. So you'll have all your questions answered by those, and a great lineup. We're joined in the panel by Dr. Holly Cheney. She is an assistant professor in pediatrics in the George Washington University School of Medicine and Health Sciences. Dr. Cheney is the vice chair of the Division of Pulmonary Medicine at Children's National Hospital. And we're also joined by no stranger to the OI community, Dr. Jo Morani. She is the chief of section on heritable disorders of bone and extracellular matrix, National Institute of Child Health and Human Development. She leads the NICHD Osteogenesis Imperfecta research program, in which clinical and bench research are fully integrated. Also joined by Dr. Reet Sutton, is a board certified in both clinical genetics and clinical biochemical genetics, and provides medical care for individuals with inborn errors of metabolism in Texas Children's Hospital Metabolic Clinic in Houston, Texas. And finally, this is a huge lineup. Everybody should be excited. I think Michael, you've pulled out the best of the best here. Dr. Megan Wallace specializes in the care of pediatric orthopedic conditions and director of the Osteogenesis Imperfecta Clinic at the Children's Hospital and Medical Center of Omaha, Nebraska, specializing in lower extremity conditions. So I don't think I've forgotten anybody, Michael. I think it's a huge roundup, and I think we're really pieces of time for these positions being making themselves available, but also for the broad contribution and commitment to the OI community. Because without them, we wouldn't have the quality of life for our children, ourselves, and our families. So on behalf of the OI community, I want to thank you all for your time this afternoon. And I think on that note, Michael, I think we should hand over to Frank to kick us off on the first presentation, if you would. Thank you very much, everybody.
Okay, thank you very much, Jacinta, for the introduction, and thank you everyone for attending this session. So I'm going to share my presentation, and here it should be. Oh, it's just a lot of overlay, so I can't make it bigger here. F5, no. Okay. Usually the screen thing is on top. Anyway, so that's what I can show here. So I was asked to talk about the medical treatment of OI.
Dr. Rausch, can I interrupt you for a moment? Can you go to
drug therapy of OI, and after that we will have the orthopedic treatment. So when we talk about the drug treatment of OI, it's important to realize that there are several problems in the bone of OI. One is that there is a low amount of bone, which we can see with a low bone density reading in most people with OI. And the other aspect of it is that the quality of the bone is not good. And that's something that's much more difficult to assess, and which we don't really see on any radiology measurement that we usually do in clinic. It's also important to realize that the treatments that we have for now, they increase the amount of the bone, but they don't change the quality much. The next consideration is that there is also, of course, changes in the shape of the bones, as we see often in particular in severe OI in babies who are often even born with deformed tibia or femurs. And if you have such deformities, so the bone is not straight, then the medical treatment will not do that much. So for this kind of problem, you will need surgical intervention, and that's what the next talk will be about. So when we talk about medical treatment, the type of medical treatment that has been available for many years is bisphosphonates, and that has been given worldwide in many places. There is all kinds of bisphosphonates that have been used to treat people with OI. Most centers give intravenous forms, and the most widely used are pamidronate or zoledronate, but there's also neridronate and depending on the country, other types of OI, of bisphosphonates. What they have in common is how they work in principle. So the bisphosphonates are drugs that when they are given either as a pill or as an infusion, they enter the bloodstream, and from there they attach to mineralized bone. And then they stick to that bone and are then taken up by the cells that resorb the bone. So these cells are called the osteoclasts, and they eat up the bone that contains the bisphosphonate, and that's how the bisphosphonates get inside of these cells. And once the drug is inside of the cell, it inactivates it, as can be seen here, that the cell is moving away from the bone and does not work there anymore. So that is the principle of how these bisphosphonates work. The effect of that is that the destruction or the removal of a bone substance is slowed down, whereas there is still bone formation going on, especially in children. There is always a lot of bone formation going on. That's how growth works. And therefore, the amount of bone increases rapidly when you give bisphosphonates. So this increase in the amount of bone you can see in clinical tests by the bone density. So this, on the left side, you can see the bone density machine. Our main place where we measure the bone density for clinical purposes is at the lumbar spine. And on the right side of the picture, you can see the bone density changes in patients who started the treatment at the time with pamidronate. The gray area shows the normal range for bone density depending on the age. And you see several patients who started the treatment at where the arrow is placed. So this indicates the age when they started the treatment, and in each of them the bone density increased. And so in the meantime, we have treated about 400 children with OI, and bone density is going up in all of these children. So this is something that is very consistently observed. So this measures like the short-term effect, or within a few months, you can see this increase, and then it continues over the years. We then looked at the long-term effect when we give bisphosphonates to children early on, so when they are toddlers basically, or babies, and then continue following the effect of the treatment during their growing years. And then we look again at the end of the growth period, what are their bones looking like. So here we have two examples of spine x-rays. That are, so two patients that started the treatment at close to 4 years of age on the left side, and another patient where the treatment was started as a young baby, just a few months old, on the right, two x-rays. And the first x-ray, so the leftmost x-ray is at the start of the treatment, and then next to it on the right side is the x-ray after many years of treatment. And what you can see in these children that had vertebral fractures when the treatment was started, that with the time, during when they received this bisphosphonate treatment, and the growth helped to change the shape of the vertebra. So this is an effect that you can see only in children, of course, because their bone shape is still changing due to growth, and so vertebral fractures can reshape in children. This is something that you cannot see in adults who have had vertebral fractures. So we had a study where we looked at the x-rays of all the children who had the treatment start before their 5th birthday and had continued until they stopped growing, and many of these vertebral fractures improved over time. So the effect of the treatment on long bones is not as dramatic. Here is one observation from a Japanese study where they made an arrow for each fracture that these patients had before and after Bamidronate treatment was started, and you can see that the arrows are fewer on the right side of the panel, so they had fewer fractures. And many studies have been done that did similar observations before and after the start of treatment, and usually the number of fractures decreases by 40 to 50%, but which still means that these children still have a lot of fractures. And as I showed at the initial slide with the deformed tibia, some fractures simply will not be avoidable with any medical treatment because they are due to deformed bone, or where the forces in the bone are such that you just need surgery instead of medication. All right, so this is the well-known treatment with bisphosphonates. There's certainly a lot of room for improvement over bisphosphonate treatment, and that's why a lot of studies are going on to find new drugs to treat OI. And one of the more advanced types of medications that has been tested and is still being studied is denosumab, or Prolia as it's called in the pharmacy. So I have repeated the bisphosphonates as comparison on the left side of this picture. And on the right side is denosumab, how this drug works. So as I said before, the bisphosphonates, they stick to the bone. And it's important to realize that they stick to the bone for a very long time. So they have an effect over many years. Whereas the denosumab is based on an antibody that's injected into the patients, and the antibody will inactivate the osteoclast, but in a much shorter period of time than the bisphosphonate, because once the antibody is out of the circulation, the drug has no more effect. And in adults, denosumab is given every 6 months because the antibody is present in the circulation for at least 6 months. In children, that's a bit less clear how long this drug is active. So there's one early study here from 5 years ago where they gave denosumab to children with OI. On the left side of the picture, you can see that bone density went up in these patients. And on the right side, you have a biochemical measure of the activity of osteoclasts or activity of bone resorption that they measured once per week, basically, after they gave the injection of denosumab. And you can see that between 3 weeks and 56 days, which is 8 weeks, these lines go up in most patients, meaning that their bone resorption activity is already returning. So the duration of the treatment effect is much less than in adults when you treat in children. And that can be a problem, as we saw in some patients that we treated here with denosumab. So this on top, you can see the effect on this bone resorption marker. And when we gave denosumab, as indicated by these small arrowheads, the bone resorption seemed to increase each time they came to the hospital for a new injection. On the lower panel, there is the bone density, which suddenly decreased between two injections because the treatment effect simply was not long enough to maintain the bone density elevated between two injections. So that's a bit of the problem with this drug, that in children you don't really know how long the treatment effect will last. So the study, the more formal study with a larger patient population is still ongoing and has not been published. So we don't really know what this bigger study is showing. Another treatment type is based on a type of drug that's called anti-sclerostin antibody. And sclerostin is a natural protein that everyone forms in their bones. And this protein is slowing down bone formation. So when you give an antibody against this, it will speed up bone formation. And there is one study that has been published in OI on that from a few years ago, which showed that this bone formation marker called here on top P1NP is increasing after a few injections of this drug. And at the same time, this bone resorption marker called CTX on the lower half of the slide is decreasing. And these patients also had an increase in bone density, but this was only a short-term study. And there has been a study going on over a longer period of time with this drug, but this has just been recently finished, and we don't have any publications about this effect of this study. So that's the two newer drugs that I just wanted to mention. And finally, I would like to mention that many people are working on OI at our hospital, and we have also many collaborations outside of Shriners Hospital, and some of the names are listed here. Okay, so thank you for your participation here.
Thank you so much, Dr. Rausch. This is fantastic. So again, I see lots of questions.
You're muted, I think.
Dr. Rausch, can you hear me? So thank you so much. We're going to now move on to Dr. Franzone, who will be talking about orthopedic treatments.
Hello, do those slides come through?
They look good, thank you.
Terrific. Well, hello. Warm greetings from Wilmington, Delaware to the OI community around the world, and a tremendous thank you to the OI Foundation for this virtual conference. Today, I'll be discussing the orthopedic aspects of OI care. There are no pertinent disclosures for this talk. And what we've covered so far, both earlier in the day and during Dr. Rauch's talk, is really critical. We've talked about what OI is. We've established that there is a broad range of clinical severity, and we've discussed the medical management of OI. And this is critically important for this talk as well. Orthopedic care does not happen in a bubble, and the medical optimization of bone health is really important for optimizing the outcomes of our orthopedic interventions. So our outcomes and successes really do hinge upon optimized medical management with attention to nutrition and vitamin D levels, focus on exercise, and monitoring of bone density levels. Really can't emphasize enough the connection that we know exists between muscle strength and bone strength. And for this reason, because there's a direct correlation there, it is particularly important to have an element of routine safe exercise as part of our OI care. We really strongly believe that there is something that almost anyone with OI, no matter how severe, can do to safely increase activity. And this is an important part of care. The way I look at this talk is really kind of like the tip of the iceberg. To talk about all of the aspects of orthopedic care within 10 minutes, we can really only touch very briefly on each topic. Each topic could be the focus, honestly, of an hour or so of discussion, but we won't subject you to that today because we really want to give the maximum amount of time for you to be able to ask any and all questions on your mind. In terms of the orthopedic manifestations of OI, there are many. This is certainly not a comprehensive list, but I will review some of the conditions that we treat most commonly as orthopedic surgeons with an interest in OI, and we'll move from head to toe to discuss each of these. Focusing first at the base of the skull, where the head essentially meets the spine, there's a condition called basilar invagination, which can progress over time. It is more common in folks with severe OI, and it's protrusion of the uppermost parts of the cervical spine, essentially into the area that the brain inhabits. And this happens over time as depicted here. And if symptomatic, this may require surgical intervention. And this is something that we'll often collaborate with our neurosurgery colleagues for. Moving to the spine at large, there are a number of spine deformities that also are the focus of orthopedic care. Scoliosis is a curvature of the spine. It's really a three-dimensional deformity of the spine, and if progressive to a certain extent, may require a surgical instrumentation and spinal fusion, as shown here. Looking at the spine from the side, there is kyphosis, which is a forward hunch of the spine, as shown here, or lordosis, which is the opposite, oftentimes referred to as sway back. And both of these require orthopedic attention and monitoring as well. Moving to the upper extremity, progressive deformity of the upper extremities that may interfere with function and fractures of the upper extremity are a significant focus of our orthopedic care. The elbow has a few particular conditions that do deserve special mention, one of these being olecranon fractures. Now, these fractures are elbow fractures that happen most commonly in teenagers with a milder form of OI. I show these three cases here because this is common enough that these three young boys actually all presented within a few weeks of each other. Because of the pull of the really strong muscle, the triceps muscle in the back of the upper arm, these fractures do tend to be out of place or displaced and often require surgical intervention to bring the pieces back together, as shown here. Another condition at the elbow deserves special mention, and this is radial head dislocation. In these pictures on the left, you can see this is an OI patient with maintained alignment of the upper aspect of the radius bone, that's one of the bones in the forearm, and the bottom part of the humerus. Whereas this patient on the right here, over time, has gradually developed a dislocation of the radial head, and it is not properly in alignment with the bottom part of the humerus bone. And why is this clinically significant? Well, it does affect the range of motion of the elbow, and it can cause discomfort and a prominence on the elbow that can interfere with function. This is common, particularly in folks with type 5 OI, but does happen in other types of OI as well. Moving down to the bottom part of the spine, where the spine meets the sacrum, there's a condition called spondylolisthesis, which happens most commonly in ambulatory OI patients and involves a slippage of usually the lowest vertebral body in the lumbar spine, the fifth lumbar vertebral body, moving forward on the sacrum, as shown here, and this also requires monitoring over time. Moving to the pelvis, there's a particularly challenging condition we face as orthopedic surgeons called acetabular protrusio. This also is more common in folks with severe types of OI, but is seen in all types of OI. And this is envelopment of the femoral head, which is seen here at the top of the femur bone, literally into the pelvis. This tends to be progressive over time and is also shown in a 3D model depicted here. Why this is clinically significant is it also affects range of motion of the hip. It can be a painful condition, and very importantly, can lead to fracture of the femoral neck, which is a challenging surgical condition. Another deformity in and around the hips is called coxa vara, and this is a progressive deformity in the upper part of the femur bone, as shown here, where it tends to form more of a right angle over time, and this can affect motion of the hip and can also affect gait. Moving down to the lower extremities, progressive deformity of the lower extremities, again, interfering with function, and lower extremity fractions are a significant focus of our orthopedic care as well. As orthopedic surgeons, we take care of a lot of OI patients with leg length differences, as shown here, where one leg is longer than the other, or various forms of malalignment of the lower extremities. This patient on the left here has a knock-knee alignment called valgus, where the knee tends to veer inward, as opposed to the opposite of that, which is called varus or bow-leggedness, as shown in the picture here on the right. And the ankles and feet deserve attention as well. Many of our OI patients also have a valgus deformity at the ankle with an inward tilt, as shown in this clinical photograph and the x-ray here. And for children with growth remaining, we do have an operative procedure that can help this deformity over time. Flat feet are very common in OI and may range in severity. And it's important to note that the treatment, if any is needed for foot deformities in OI, is a very individualized, is treated on a very individualized basis. Now that we've reviewed a lot of the conditions we commonly manage in terms of the orthopedic management of OI, let's return to our overall goals of orthopedic treatment. Our goal is to maximize each patient's or each child's function and to help each child meet his or her developmental milestones as close as possible to his or her peer group and to decrease deformity and fracture burden. I like to think of OI care as, in terms of orthopedic care, as really falling into 3 different phases, and we'll go through each of these phases. The first being monitoring or preventative care. This would usually take place at a routine visit, oftentimes annually, and ideally will be performed with a multidisciplinary team. This would be a visit during which medical care is reviewed. Both physical and occupational therapists can play a critical role in helping to maximize each patient's function and mobility, as well as various seating options in a seating clinic, monitoring of bone density, monitoring of spine and lower extremity alignment, monitoring of gait over time, and a very strong emphasis on patient-reported quality of life assessments, as Dr. Tosi covered earlier today. And this is really a critical element of establishing each patient's baseline over time during these routine monitoring visits. An additional aspect of care would be fracture care. Now, fortunately, the majority of fractures in children with OI can be treated non-operatively or without surgery. We emphasize home splinting and trying to avoid ER time as much as possible. Each of our patients and families has one or multiple fracture kits, and the specific elements of this fracture kit may evolve and change over time with a child's growth and development and preferences. It's a very important concept to avoid prolonged immobilization, to immobilize for the minimal amount of time for the fracture to heal in order to avoid a fracture cycle. Immobilization tends to weaken the muscles, which weakens the bones and can predispose a child to entering a fracture cluster. For neonatal patients and young infants, oftentimes a soft, lightweight cotton wrap is enough to provide stability until callus develops. For a more in-depth discussion of fracture care in neonates, I would direct you to this toolkit on the OIF website. This is an example of a humerus fracture treated with a soft wrap for the arm and a swath around the body without surgery. Nowadays, with Zoom and various ways of interacting with patients being in different locations, we can oftentimes help with this home element of fracture care without the family having to travel. And this has been an important part of care, especially during the pandemic. This is an example of a femur fracture in an 18-month-old girl, which went on to heal very well without surgery. Until a few years later, at the age of 5 years old, the bone fractured in the same location while on a slip and slide. And given a different age and a different type of fracture, we elected to treat this with surgical intervention with an intramedullary rod. That brings us to the third phase of care, surgical care. The big question here for many children and families is when to rod the bones of both the arms and the legs. This is an important question. The way we look at this is there's no set minimum age, but rather the indications are progressive long bone deformity that is interfering with development or function, recurrent fractures in a particular bone, fractures that have perhaps healed with deformity or have not healed. That's called a non-union. Regarding the upper extremities, interference with function is a critical indication. And it is important to note that before an elective procedure, such as a realignment and intermedullary rodding, the bone quality should be optimized. And the goal of the procedure is stability and alignment. This is a 2-year-old boy with progressive deformity and recurrent fractures in both femurs, who underwent realignment and intermedullary rodding of both femurs during the same procedure with telescopic intermedullary rods. Went on to heal nicely, and at 6 weeks had resumed ambulating. There are different types of intermedullary rods. This is an example of a telescopic rod. This is a Fassier-Duval rod that is anchored at either end of the bone and elongates with growth. There are threaded rods, such as these 2 rods shown here, that do screw into one of the ends of the bone, but does not have an ability to telescope or elongate with growth. And then there are non-threaded, non-telescopic rods, as shown here, commonly used in the smaller bones of the forearm. The different type of rod to be used is really determined by a number of factors, the size of the bone being one, the personality or quality of the bone, and the age of the patient. And this should be an individualized discussion with your orthopedic surgeon. This is an example of a telescopic intermedullary rod, again, anchored at the upper end of the bone and the lower end of the bone. And you can see with time, over a 4-year period of growth, each of these components of the rod has remained anchored and telescoped with growth, bringing the junction of the 2 components of the rods from all the way down at the bottom of the bone up to the middle of the bone. This was then revised due to growth to better stabilize the full length of the bone. Now, the rods do not always behave as well as this and do not always perfectly telescope, and we must accept that rods are certainly not perfect. This is an example of a rod that has had bone grow over the top of it up at the hip, and this particular rod has not maintained its fixation in the distal or the knee part of the femur. It is still doing its job, but we must recognize that telescopic rods do not always behave perfectly in OI bone. In fact, rods are oftentimes certainly not perfect. They can bend and break, as shown here. They can migrate or move out of position, as shown here. Non-unions can develop around rods. This is when the osteotomy or fracture site does not heal. And if too large of a rod is used, the bone around the rod can melt away, and this is called stress shielding. Now, these are examples of orthopedic challenges that we very much enjoy treating and keep working to improve the treatment options for these, a little bit beyond the scope of the talk, but we'll certainly welcome any questions on these topics. Which brings me to the final thought regarding the surgical aspect of care, in that the surgical procedure is really one small piece of the full orthopedic experience and healing process. And it is important to have a dedicated perioperative team of folks who are comfortable with OI, anesthesiologists who are comfortable with OI, as well as comfortable managing pain and helping kids through the surgical experience, as well as other abilities for physical therapy, ideally aqua therapy with pool capabilities, and a multidisciplinary team to guide each child through the surgical experience. And on that note, I'd like to thank our multidisciplinary team here at Nemours, and thank you very much for your time and attention. We look forward to answering your orthopedic questions, and any questions we do not get to in this allotted time, please do not hesitate to reach out. Thank you very much.
Dr. Franzone, thank you so much. That was fantastic. And I'm loving that last slide you have of all the stuffed animals. I was just noticing all the the cast and whatnot.
That's right.
So next up, I would like to introduce Dr. Kara Ayers, who's going to be talking about psychosocial considerations for children with OI. Dr. Ayers.
Yeah, thank you, Michael. And thank you, Dr. Frenzone. I'm going to take a similar approach in the iceberg metaphor, and that there is also a lot to cover related to the mental health and psychosocial impact of OI in childhood and adolescence. So I'm going to try and focus most of my time on strategies and recommendations. And I'm also happy to take any questions afterwards. And I'm also going to drop a quick link to these slides in the chat room in case you want to access them later. All right, so this is me. I have type 5 OI. I'm a full-time wheelchair user. And one thing I wanted to highlight about my background is, so my professional role is I'm the associate director of our UCED, UCEDD. And I would highlight that because if you live in the United States or any of the territories, you have at least one UCED in your state. And many families of kids with OI don't realize that it qualifies from a policy sense as a developmental disability in almost all cases. So the UCED may be a resource that you haven't tapped in yet. Another thing I would highlight is last fall, I founded a disability research lab. So if you are the parent of a young adult or even a teenager, a high schooler interested in research, especially psychology, reach out to me. We would love to have them join. We have overrepresentation of researchers with OI, but we would love to add more. So something else I'd like to highlight. So today I hope to just touch on some common themes among psychosocial aspects of OI for children, adolescents, and their families. I want to summarize the research in this area and really, again, focus on some coping strategies and hope that you can come away from this talk with some ways to promote resilience among children, teens, and families as a whole. So what does the research tell us about mental health and OI? I'm happy to see that there's been a steady uptick, especially in the last 10 or so years, in more focus on psychosocial and kind of non-medical aspects of OI. And what can be really helpful is what's called a systematic review in research looks at multiple studies. So a lot of these studies that we have are relatively low sample sizes. So they might have 15 here and 45 here, but a systematic review allows you to combine those and look across different themes. So it gives a wider picture. And some of the themes that emerged that I wanted to point out today, and these themes have really in large part remained pretty steady over the years. So stereotypes of high intelligence and euphoric personality, and coming from that, some recommendations that we see from those studies are from some qualitative, some quotes that were taken from some of those studies as well. So sometimes you see focus on academic activities over physical activities. And this isn't necessarily a positive or a negative thing. So this may be a way of honing in on a child's strength, but it may also be a pitfall of overlooking what physical activities are an option for that child. As Dr. Frenzone mentioned, sometimes it can be challenging to find what activities are a good fit, but there's something out there for almost everybody. Another point I wanted to highlight is the positive outlook that is over and over again kind of reinforced and emphasized by lots of people that surround kids with OI often. It may sometimes at least be a response to parents' expectations. So I think that I say that with caution in that some kids almost feel the need for permission to feel sad, disappointed, or angry. And we all know that those are typical responses, especially to big disappointments and painful fractures. And but the flip side of constantly being reinforced for being so strong and so positive can be that feeling that it's not okay to feel otherwise. So sometimes it helps to talk explicitly that it is okay to feel otherwise, and that you can both be strong and you can be sad and you can be scared. So that would be a recommendation. So we see across the board of these studies tendencies for high rates of anxiety, but low use of psychological support. And I myself am a parent of 3, and one of my kids has a disability, and I know the feeling of just feeling overwhelmed by all the therapies and doctor's appointments. And so I think one of the things we noticed in the study when we look at maybe the why behind more kids who have high anxiety, but aren't seeking or aren't in services therapy for that, it may be related to kind of that overwhelming feeling of medical appointments and therapy. But I would really encourage you to keep a pulse on that anxiety, to look at how you can support coping with that as well. And now with telehealth options, at least our family is feeling sometimes a little bit of easing of those appointments, because we can mix in, especially with therapy, we've been able to mix in a telehealth option. So pain, fear, isolation, reduced functioning, uncertainty can combine, and that's kind of the perfect storm for anxiety. And then the last theme I wanted to focus on was this coping and resilience. So we see a need for psychosocial support from peers. We see also an adaptation by learning new skills when the functioning is reduced, and high levels of resourcefulness. And that's a real strength that carries on through adulthood with OI. So again, unfortunately, OI can present this kind of perfect storm for anxiety, this uncertainty. There are a lot of pain and bodily sensations that can contribute and be confusing. We can feel anxiety in our body as well. And there's an emphasis on caution, and I'm going to focus a little bit more on that in a couple of slides. But I did want to mention that medical trauma is an area of increased interest. So it's understudied in research, but it's reported as a relatively common experience shared by many adults with OI. And it can be triggered by smells that smell what they remember as anesthesia, sometimes noises, beeps in hospitals. And so it can be a really scary experience and frustrating, because it can feel almost beyond us, this trauma triggers. So if you're seeing instances of that and really strong reactions to providers and medical treatments, don't hesitate to engage child life specialists, pediatric psychologists, and other teams of your other members of your medical team to reduce that re-traumatization. A quick note on pain. Again, this could be its own session in terms of the complicated relationship between pain and social and emotional functioning, but just wanted to highlight that, of course, there's acute pain and then there's chronic pain. And a theme that I'm very interested in that's emerging in the research is pain-related stigma. So, and this is the idea of, especially if symptoms aren't verified, and in the OI world, this could be feeling like there was a fracture, but it not being verified on X-ray. And I know many of you may relate to the experience where sometimes the medical providers come into the room and they think they're delivering good news, and they say, "Good news, there's not a fracture." But I can tell you, as the person who feels like you're broken, that is mixed news at best. So there can be a stigma element, and it can be particularly difficult for adolescents during that identity formation period. So some strategies, really building resilience like a muscle. If you're looking for a specific tool, I like the Mind Up curriculum. It's available on Amazon in different grade levels. Some schools adopt that curriculum for all students. So it's not disability specific, but it's got some good exercises in there to talk through and help you as a parent to talk through some of these topics. And really just opening those dialogues about triggers, about coping strategies, feelings, uncertainties. Many times kids, as their anxiety builds, they'll ask a lot of repetitive questions. What are we doing today? Or, so a visual schedule can help with that. And you can kind of adapt them with the maturity level of the child. They can go from, pretty young child, preschool like images, all the way up to more like an icon that you would see on your phone for an older child. So it gives a quick visual of what to expect for the day, and you can refer them back to that when they're asking those repetitive questions. Role models are so important, and I'm excited for when we can get back together in person, both in our regional and our national gatherings. But it's essential to build those self-advocacy skills. So any opportunity you have when someone asks either, what does she want for dinner? Because that sometimes happens to us in restaurants as smaller people, or at the doctor's office when you want to let them report their symptoms to start out with. So I also focus on the word interdependence instead of independence. All of us need help, whether you have a disability or not. I know I don't live off the grid. No one in my family does, whether they have OI or not. So, it's all about figuring out how to do what you can on your own, but also working with others to get where you want to go. So another strategy that I wanted to pass on today is working on replacing be careful with some awareness building and problem solving. And the goal around this is twofold. So one is you, like me as a parent, are probably tired of saying be careful. And anytime that we say anything repetitive like that, we lose compliance anyway, so it's not effective. But also adding these other 3 skills can really increase your child's kind of body awareness and hopefully decrease some accidental fractures. So the first tip would be add specifics. So if you see a child kind of starting to climb, really pointing out to them how they need to assess their environment. And so pointing out something like, hey, that chair could tip over. How can we secure it? Do you need my help? So figuring out if they want to do something, if they want to try something, asking them, how can we do it safely? Don't immediately say that you can't, but let's plan it together. The second tip would be fostering awareness. So looking around for kind of clues to, I know that when I'm was looking for a new dentist the other day, and I'm driving by a few and I'm seeing even the parking lots. How bumpy are they? What's the incline? So building those skills are things like, do you see how the floor is wet and shiny? It might be slippery. Let's walk over here. So another, as you're planning an activity that might be new for your family, YouTube is a great place, or videos are a good place. We use this often as our families say, let's see if we can find a video online to know what to expect. And I've even had families that have used that to assess whether rides in Disney World are safe or not, because sometimes the ride itself can be okay, but at the very end, it's a big lurch. So, and last, encourage problem solving. So elaborating on those concepts with just helpful examples and illustrations, really reinforcing when they spend the time to figure out how to do it safely and achieve what they want, but also do it safely. And last, don't overlook the impact of ableism on mental health. Sometimes we get very focused in our OI world of OI specific challenges and interventions, but really when your child enters adulthood, it's much more likely that most of the challenges are going to be more global based on being an adult with a disability and the impact of ableism. So it's important to kind of widen that lens. And the hashtag OI Pride is a good place across social media to look at places where people have are building, because it's an ongoing process, pride. And I use the image of a smokestack to describe ableism, which is just devaluing of disabled life. And for me, ableism sometimes is very explicit. So we were on vacation not long ago, and my husband, who also has OI, wanted to take our daughter on a little ride, and they said, no one can ride this ride if you can't walk. So to us, that was an example of very explicit ableism. You could see the you can see the smoke, but as the smoke gets farther away, it's harder to point out, but it still impacts your life. And that's how most ableism feels, at least to me. And another reason I like the smog metaphor is that we all breathe this in, including people with OI. So it takes active work to teach yourself that your life does have value with OI, because unfortunately society, is sometimes telling us otherwise. So I'm happy to take your questions, and also wanted to share my contact information, email or Twitter, and you're welcome to contact me after today too. Thank you so much.
Dr. Ayers, thank you so much for that. That was so thorough, so engaging, and so important for us to be talking about at a session like this. Thank you. So to everyone on the call, we are going to now transition to a large Q&A period. We ask that you please keep your microphones muted still, just so that we can go through the questions as we've received them. We've received a large number so far. So we are going to try to organize some of them into basic categories. And again, in addition to the 3 excellent speakers we just heard, we also have a group of panelists who are going to be contributing as well. So you may see other names and faces come up as well. I want to start off with some questions about bisphosphonates. So those came up both in the registration questions as well as in the chat here as well. So one question we're seeing is, what are the known long-term effects of bisphosphonate treatments, good and bad? And I think this is also thinking about not just in years, but maybe even decades if we have that information.
Was that from me?
Yes, I'll have you go first. Thank you.
Okay, so many things are being discussed with bisphosphonates in terms of side effects. but what we have observed in patients is very little, I have to say. So things that are being discussed is osteonecrosis of the jaw. So you will find many news articles about this. So meaning that, for example, when you extract a tooth of a person who has had bisphosphonate treatment, the hole will not heal properly. This has been observed in people who had bisphosphonates with cancer, but not in people who had bisphosphonates because of OI, but it may still happen at some point. Other things that have been discussed is that people on bisphosphonate treatment can have unusual fractures. This is mostly reported in people who have osteoporosis after menopause. In OI, these unusual fractures, what they call unusual in people with adult osteoporosis, often is quite a typical fracture. So it's difficult to say whether you had a fracture because of the bisphosphonates or despite the bisphosphonates. I think it's despite of the bisphosphonates. So basically, these are the two big types of side effects that are being discussed in the medical literature, but which we are not so convinced are applicable to OI.
Great, thank you. Would anyone else like to comment on that before I move on to the next question?
So I'd like to add another thought.
Yes.
Bisphosphonates are not only in the pediatric world, bisphosphonates are not only used in children with OI, they're used perhaps in children with renal disease. They're used in other conditions in which children are given need to be given a lot of steroids, and because of that have weak bones. And one aspect of a downside of bisphosphonates is whether you get to a status of adynamic bone, meaning that the cells have been so impaired. Dr. Rausch showed the image of osteoclasts absorbing, it's like the Trojan horse, the osteoclasts absorbing the bone that contained the bisphosphonate. Whoops, that osteoclast is a goner. But osteoblasts and osteoclasts are in communication with each other and influence each other. And so whether in the long run you get to a status of adynamic bone, a reduction in turnover, a reduction in microcrack repair. And I think there's no drug that's perfect. There's always, these are like the two sides of the same coin. You can't split the coin down the middle. These kinds of things are going to be intrinsic to that class of drugs that includes bisphosphonates that we call anti-resorptives. And this, it would be hoped, and the evidence from adult studies and from animal studies, that the newer drugs that Frank talked, especially the anti-sclerostin antibodies, which have been really quite well studied in OI mouse models, and have a different mechanism of stimulating bone formation, might be able to avoid this pitfall of anti-resorptives.
Dr. Marini, thank you. Any other comments before I move on? I actually, on that note, Dr. Marini, we were getting a lot of questions in the comments about anti-sclerostin treatments, and kind of some, kind of asking like, what is the status update on that? And also, do we know the relative level of like what the risks are with those treatments? Can you speak on that briefly?
A little bit on status, perhaps.
Mhm.
I think there are two different companies that have anti-sclerostin antibodies that are going into pediatric trial. They've been very cautious about going into pediatric studies, which is a a factor in their favor. But I think we really need to get into the pediatric studies. And so I think for these studies, it will be important to consider whether the simultaneous administration of a bisphosphonate with its anti-resorptive characteristics might, in a way, mask some of the potential beneficial effects of the bone stimulating drugs, and that an argument, a very solid argument, I think, could be made for either people who, either this kind of study being entered into by young people who've been off bisphosphonates for a while, meaning years,
Mhm.
or who had not been exposed to bisphosphonates in the first place. I don't think it's sacrilege to suggest that depending on the type and severity of OI, that this is a reasonable approach. On the downside, like the Prolia, this is a short-acting drug. This is not going to have, something, the effect of this, like the effect of bisphosphonate. You can see the amount of bone mass hanging around for years after bisphosphonate is discontinued, at least several years. I don't mean to imply it's a decade, but for 2-3 years, sometimes longer. And that won't happen with these short-acting drugs. And so whether the short-acting drugs, I kind of think of it as solidifying or sealing in, if you get a beneficial effect of increasing bone mass from the bone stimulatory drug, which works on a different cell type, by the way, it works on osteoblasts, then you want to seal in that gain in bone mass potentially by following it with a dose or two of an anti-resorptive like a bisphosphonate. So in the long run, we may well wind up with a multi-drug approach using two different mechanisms to get the benefits of each.
Great, thank you. So thank you for everyone who keeps typing in questions. We have a lot more to get to. On a kind of similar note, so a parent is asking about what available treatment options or preventative care options are available for particularly children with more mild OI types who say their child does not meet an institution's minimum break requirement to receive bisphosphonate treatments. And I think this is probably like a broad, I think almost anyone can answer this, like what things should they be considering?
I think, hi everyone, I'm Reed Sutton from Baylor College of Medicine. I think there are a variety of things to consider. I think just overall good bone health, so ensuring good diet, including adequate amounts of calcium and vitamin D, whether that's from dairy in your diet or whether that's from supplements. Exercise, Dr. Franzone kind of mentioned briefly in her nice talk, but the importance of kind of muscle strength and the interaction between bone and muscle. So healthy, safe exercise is also very important for building and maintaining bone strength.
Great, thank you, Dr. Sutton.
I think she also mentioned, maybe you should say too, therapy services. So again, that is a good part of it. So, physical therapists, can certainly help with core strengthening sorts of things to minimize the risk of injury. Also, they can kind of show children how to safely do certain things. Carol was kind of talking about in her talk, I think nicely as well, to kind of remind you, but certainly there are physical therapists that can help out with those sorts of things too, things that people want to do. How can you do those safely?
Great, thank you. I actually want to, on a sort of similar note, one person was asking about, are there any recommended supplements for particularly mild children with mild OI? And, they're talking about specifically like vitamin D or calcium. This is sort of a classic OIF National Conference question, but I think it is important to answer every time. Can someone speak upon, are there sort of baseline supplements parents should be considering for their children?
I think from Joan Marini again. I think from just a pediatric standpoint, it's amazing. Everything good. I keep talking about the two sides of a coin. So parents became, and I'm going to address vitamin D. Parents became so concerned about sun exposure in children that children could practically not emerge from their houses without being slathered with sunblock. And so they weren't getting the sun exposure that they needed to build their own vitamin D. And it's amazing how many children, including OI children, when one measures a vitamin D level, are really lower than they should be. So I think this could be, you certainly want to have, all these things are, are things where you want to make sure you have an adequate level. You want to have an adequate serum of vitamin D, and you might need supplements rather than, but you could also spend 30 minutes outside without the sunblock on every day. But many of our patients are taking supplements, at least intermittently. You want to have adequate vitamin C because that's a cofactor for so many collagen enzymes. You want to have, adequate dairy products, but you can't push any of these to the extreme. None of them are going to be curative.
Gotcha, thank you. I want to switch directions slightly. So also, as just an announcement to the audience, so I have questions upcoming for our orthopedic surgeons as well as for Dr. Ayers and for others as well. We are lucky enough to have Dr. Hollis Cheney on this call as well. She's a pulmonologist at Children's National Hospital in Washington, D.C. If you have questions about lung health, she is our expert and she will be more than happy to weigh in there as well. So I want everyone to know that resource is available if you have lung health questions. So one thing I want to get to, I want to transition to our orthopedic surgeons, so Dr. Franzone, to Dr. Wallace. We're getting some questions about the spine. So someone was asking, what degree of spinal deformity should intervention be considered for both scoliosis and lordosis/kyphosis?
Yeah, that's a great question. One thing that, I would say, a lot of OI care, spine care is very individualized. Monitoring spine alignment is an important part of that routine surveillance aspect of care. We monitor spine alignment at minimum on an annual basis. And if there's, a scoliosis or a kyphosis or lordosis, as you mentioned, that may be requiring treatment, that may be more frequent. And the reason that I mention it's so individualized is there isn't one magic number or degree of deformity that necessitates a certain intervention. bracing for the spine is something that's somewhat controversial in the setting of OI, but depending on OI severity and bracing resources can play a role on an individual basis. And then there are some degrees of curvature, as scoliosis curves, if you're familiar with a Cobb angle, enter into a range of, the neighborhood of 50 degrees would be where a surgical discussion may start happening, maybe even sooner. But again, it is individualized based on how much growth is remaining, how quickly or slowly the deformity may be progressing, and how other aspects of health are affected. Like with Dr. Cheney being on, lung health and pulmonary function can be significantly affected by spine deformity. So these other considerations play a role in whether or not a surgery is indicated or discussed, and when the timing may take place.
Great, thank you. So here's a question, and I am not totally sure who will be best to answer this question. So someone is asking, why do some hospitals delay doing bone density tests until the child is 4 to 5 years old? Doesn't that seem too late?
So I can maybe answer that quickly. So to some degree, it may depend upon the type of machine that the hospital has. There are a couple of different manufacturers of machines that measure bone density, and not all of them have normative values for children below certain ages. And so if the machines kind of do not have normative values, then institutions may elect not to offer testing because they can't provide essentially what would be a normal range for a bone density at a particular young age.
Interesting, thank you. One set of questions we're having here is another question where I'm not totally sure this applies to. Someone was asking about, is there any research or information about the new and anti-metabolite therapy for osteoporosis, but for OI? And with so they're asking specifically about is there any news about the anti-metabolite therapy for osteoporosis in OI? And I think by the group silence, I think the answer may unfortunately be no. One thing I want to then keep it moving then is, and Kara, I actually know you. I saw you type in a response to this question in the chat, but I want to ask you to elaborate it in person here. Someone was asking about, how you brought up medical trauma and how we can preemptively help minimize. We sometimes throw around the word PTSD or post-traumatic stress disorder, but how do you minimize medical trauma for our children? And can you just kind of elaborate on what you answered?
Yeah, so I think it can be unpredictable in terms of when I sometimes think of a lot of our vulnerability or risk to many mental health conditions is kind of like a cup, and we come with different levels of that cup being full, and we never really know when it's going to overflow and trigger something like PTSD. So you might have had multiple casts removed, and you've been able to cope with them okay, but for some reason on this particular day, it really triggers a lot of anxiety to the point where you feel like you can't breathe and you feel like, you feel lightheaded. And so, but having that kind of vocabulary as early as possible for kids to be able to describe their bodily symptoms, and also understanding that our body and our minds are connected. And so there really is no such thing as it just being in our head, because they're connected. So when we're feeling muscle tightness because we're anxious, that can can also cause us real pain with OI, especially if we have a fracture or an injury in the first place. So I think the broader that we can widen our emotional vocabulary, and that's a strength for us often. Verbal communication is a strength for many kids and adolescents with OI, so we can build on that strength. And really I like this question about being proactive. And I think the last point I would add is I've spoken to a few adults recently who have been they've pointed out the interesting kind of phenomenon to them that they've noticed that now as adults in certain roles of their life, they're caregivers, whether it be to their child who may have OI or to another loved one. And so sometimes they're being triggered by medical aspects of others. So again, I think it just points out that this is tough stuff that we're all coping with, whether you're a parent and you're watching your child through some of these difficult moments, or you're a kid, growing up with this. So I really do like the idea of trying to be proactive and build up the reservoir and the resilience when you can.
Great, thank you. I want to direct a question at Dr. Cheney. So someone is asking, is SIDS a great risk in OI? And are there special things we should do to further reduce risk?
Actually, I don't think that's kids with OI are at higher risk for SIDS. I don't think there's anything particularly necessary for SIDS to prevent SIDS.
Just to clarify, what does SIDS stand for?
Sudden infant death syndrome. So it's for newborn infants, and it's mostly related to kids who, like for instance, if you let them sleep in a crib with a lot of pillows and mattresses, and they can't turn their heads over and so they suffocate, or if they sleep in a bed with somebody and they would roll over on it, which I can't see happening with OI. No, but it's just common sense that just normal baby care, infant care.
Thank you. And Dr. Cheney, just a heads up, your audio is breaking up for us. So I may ask you if you could maybe turn off your video, and that might increase the quality a bit. Thank you so much. So I see we're getting a few more questions in the chat, so thank you, everyone. Another question we saw before, so this is going back to bisphosphonates, so we're jumping it back and forth a little bit here. When choosing between PAM and ZOL, is one bisphosphonate considered better for certain types of circumstances? So i.e. say like spine compression fractures or age or other things?
So, I mean, we started with pamidronate initially because that was the drug that was available, and then when zoledronate became available, that's what we switched to. I don't think there is a big difference. So the main reason that we changed is that zoledronate is easier to give because you give a single infusion just taking 45 minutes or so. And we repeat that every 6 months. And with pamidronate, you have to come to the hospital more often, and the infusions take longer. But in terms of effect on bone density or the effect that we see on vertebra, I don't think you can make a difference.
I agree with Frank. I think certainly there are no kind of clear published scientific differences between those agents for kind of some of the things that you've discussed. I have had patients indicate, particularly those that maybe were at one point switched from pamidronate to zoledronate, that felt like that the zoledronate maybe did not work as well for chronic pain for them as opposed to pamidronate. But again, that's kind of a very anecdotal thing.
Got it. Thank you. So on a similar note, so someone is saying that, with 5 years of bisphosphonate treatment and bones are hyperdense, plus with +2 standard deviations, should a person like that consider a drug holiday?
So I think that's where the importance of doing bone density every now and then comes in, because that's what we want to avoid, that somebody goes so high. So we would decrease the dose according to the bone density, if the bone density goes up to that extent. So yeah, if somebody is above a set score of 0, so my practice is to give them the zoledronate, which is our standard drug, only once per year at a lower dose, instead of giving it every 6 months. So we adjust the protocol according to the bone density to avoid going into this hyperdense range. So once you are already there, what to do? I mean, I would have to, see the exact results and what the bones look on the X-rays and so on. But I certainly would not continue full blast zoledronate in that situation.
Great, thank you. I want to switch over a bit to an orthopedic question. So this person is asking, what are the known reasons for rods to migrate in bones? And particularly asking about rush nail has migrated upwards within a few weeks after surgery.
Well, that's a good question. So, I mean, when you don't have anything securing the rod in place, so with a rush rod, typically they're smooth, or you'll have it bent over and kind of tamped in. When the bone is soft, it's just more likely to back out. We find the same thing in our patients when we correct the forearm deformities, because the forearm bones are so small that all we can get is a smooth rod or a smooth wire in, and those tend to back out more as well. So some of it's just the quality of the bone, but also kind of our limitation of what implant options we have available with smaller bones as well.
Great, thank you. This next question is, it's kind of it seems to be more of a framework question. So someone is asking, are there any times where restrictions should be placed that may delay the advancement of gross motor skills in order to prevent further, I think they mean bone deformity, where it is not a response to injury?
I'll take that one again. From an orthopedic standpoint, I mean, when the children start showing signs that they want to progress with their motor milestones, even the patients that are severe, you're not going to be able to stop them. Kids are motivated and they want to get moving, and they're going to do it on their own time frame. And there's no good research or data that shows that slowing them down is going to change your deformity. If you have a deformity in a long bone, especially if you have moderate to severe OI, that is not going to correct on its own with growth. And by delaying the children from meeting milestones, it's not going to prevent additional deformity as well. So I definitely, from our standpoint, wouldn't recommend slowing the kids down at all. I don't know if anyone else has thoughts.
I think that's a great question. A lot of times we will see, like Dr. Wallace was saying, when kids are motivated to meet those milestones, that's exciting. And, in the setting of a fair amount of deformity or bowing in the femurs or the tibias, that certainly may coincide with, a spike in fractures, but, to us, that is an indication that realigning and rotting that bone, that could be the right time to do it, because, the child has shown that motivation to walk, and we can help them with that. So sometimes those, fractures in working to meet a milestone, may be an indication that we can help with a surgery. So those are really important, and, not in the big picture necessarily a setback. One of the things that we place, emphasis on, like, a lot of us have talked about, is, being active and, kind of like Dr. Ayers said, to tell someone to be careful is, that's not so helpful. But, one of the things I also learned from my, senior orthopedic mentor, Dr. Cruz, is that, fractures will will heal, but lack of development won't, and that's why it is so important to maintain that that activity level.
Great, thank you so much. Someone is asking, does tummy time need to be modified for a child with OI? I imagine there are some other considerations there as well, but can anyone speak on that?
So I guess I would say again, as Dr. Franzone noted in her talk, that we know NOI that there is not only kind of weak bones, but also low muscle tone. And so again, as was discussed earlier by Dr. Cheney, being careful about tummy time, making sure that, they are able to kind of keep their head up and breathe. So assessment of kind of when they can do that should really be done probably in conjunction with your pediatrician or physical therapist. Like when is the neck strength good enough to start working on that?
Great, thank you. Someone was asking, can we discuss if there are gastric concerns for pediatric OI patients? I know this is something that the OIF has received this type of question before.
I'll answer as an orthopedic surgeon. Lots and lots of my patients have gastric concerns, especially the young children. Constipation is very common, and it's something that we've been noticing more and more, and especially if you start asking questions about it. So we are starting to look into that a little bit closer, and even to the point where we're adding a GI specialist into our multidisciplinary clinic because it's such a common problem that we see. I'm sure others have opinions as well.
I'd like to make a comment on it from the viewpoint of if they're at all constipated, it puts pressure on their diaphragms and it impairs their breathing. If they're at all constipated, it leads to reflux, and reflux can actually trigger asthma and can trigger recurrent pneumonia. And the younger infants in particular, when the reflux comes up, it can get into their lungs and cause a pneumonia. So it's actually quite crucial to make sure that they're going regularly.
Mm-hmm. Great, thank you. So we are actually, we have a few more questions left. So two are nutrition related. One is asking specifically about breast milk with feeding infants. Are there any things that moms can do to amp up their breast milk? Is there a specific formula substitution that would be advised or any procedure there? I can also say to the person who asked that question, I know that Dr. Krakow will be speaking at the Women's Health session. That will be tomorrow afternoon. We can put the link into the chat in a few minutes. And I know that she can answer that question as well. So we definitely have information on that topic as later on this weekend. On a slightly related topic, someone is asking, does magnesium help absorb calcium in the bones? I believe that is a, is there anyone going to jump in quickly on that? About does magnesium help absorb calcium? This was in a larger conversation talking about supplements.
So we have no special recommendations for magnesium, so I'm not sure there is good evidence that it makes a difference. So to the calcium absorption, so what we target in our recommendations is calcium, the amount of calcium per day, but not the magnesium. So we have not really given any recommendations on this because I think the evidence is not there.
Gotcha. Thank you. Someone just sent a message asking, is the new HM cast allowed to be placed on children with OI? Has anyone heard of this HM cast?
I'm unfamiliar.
So the person who sent me that message, if you want to put that into the everyone chat, and we can take a look at it again. And then we have someone asking about, so someone is asking about Lyme disease. So their child, type 1 mild OI, they have gotten Lyme disease from a tick, and they are saying, is there any recommendations or things they should be aware of when thinking about antibiotic dosage as they are considering treatment for that? Is there anything specifically that like OI, with OI that should impact that decision making?
So I would give that back to the pediatrician, you know, so because I would just say do whatever you do with any other child. I don't think it makes a difference that the child has OI when you have Lyme disease. I mean, whatever treatment schedule is used for Lyme disease can be used in someone with OI. That's not telling what exactly, you know, I would recommend, because simply I don't know.
Yeah. But there's no explicit contraindications.
No, I think it doesn't change. The fact that someone has OI doesn't change, I think, the treatment for Lyme disease.
Okay. Thank you. Someone is also asking, going back to the topic of gastro problems and constipation. Specifically, they're asking, so this is from a person, I believe, outside of the United States. They're asking, is Macrogol okay for infants of 6 months of age? They say in my country, it is not recommended before 2 years of age, but lactulose is not of big help.
I don't know what Macrogol is.
Dr. Cheney, it's Miralax. It's polyethylene glycol.
Oh, okay. Yeah. So actually we use Miralax in little kids. We use it even in infants. The other thing, infants really respond to prune juice.
Okay. Excellent. Thank you. Someone was asking, so I see we did have one question in the chat talking about, they are asking about, I'm going to interpret their question. It's saying COVID protection and concerns in kids too young for the vaccine. So I just want to make a quick note. I want to welcome anyone who wants to make a comment on this. The OI Foundation has made some resources talking about COVID-19, the vaccines, and OI. I do know that as these vaccines are getting studied and then approved for children of younger ages, that the OI Foundation is following this closely, and we are making updated recommendations on that. But with that being said, does anyone want to further make a comment about talking about the vaccine, COVID protections and concerns in kids too young for a vaccine?
I have a comment. At least around where I live, there's people who are getting a little bit careless about wearing masks, and that includes children. And my concern is with children is not just COVID, but since COVID is cut down, we're seeing a very high rate of other respiratory illnesses, a lot of colds and viruses that when they're not wearing their masks, and they're going to get sick just from those. So I can't emphasize enough the need for the mask.
Absolutely. Thank you. So we're getting a few more questions here. One is asking, so this is, someone is asking if the PLS3 mutation will be typed as OI. And Dr. Marie, this sounds like a Dr. Marini question. I could be wrong.
The answer is no.
Okay.
I'm sorry. I don't know. Wait, I just did something bad. How do I get rid of that?
Ooh.
Oh no, I'm losing. I don't want to lose you guys. But the answer is no, because so many of it is a excellent form of Thank you. It's an excellent form of osteoporosis, but it lacks many of the common features of OI bone. While admitting that, admittedly, there are no set of 5 or 6 characteristics of OI bone and genetics that define all types. But there are features that cross most of the types. And so in my opinion, and you'll notice that the people working on PLS3 sometimes call this X-linked osteoporosis and sometimes call it OI-like. It's a bona fide cause of X-linked osteoporosis, but I would not call it OI.
Great, thank you. So now I'm seeing we're getting a few questions about growth hormone. So I'm going to sort of package these together, but would anyone like to share their thoughts about growth hormone treatment when there's a growth insufficient with pamidronate as well?
I'm not sure what the questioner means.
So I think the question is asking, actually, I'll ask this follow-up question, which I think will get at this first question. So this person is asking, they're specifically asking about, say, a 12-year-old girl, but I think I'm going to expand that question out to, can children with OI be treated with growth hormone? And then are there any, if yes, are there any special considerations there?
So actually, there's in mild OI, there have been studies out of Italy treating with both bisphosphonate and with growth hormone. And in milder OI, at least, you seem to get a good combined response. I think that may have to do with the fact that there's probably less disruption of the growth plate in milder OI. I think it gets to be another consideration when you're talking about moderate OI, and yet another consideration when you're talking about severe OI. Even used alone, i.e. not in the context of a bisphosphonate administered at the same time, there's really no strong evidence for growth hormone in very severe OI, and some usefulness in moderate OI, but not in all type 4 OI. And while there are some factors that you can measure that might indicate more of a potential for success, you almost have to try it for a short period of time, meaning 6 months or so, to see. I can say that some moderate severe OI patients have been brisk responders to growth hormone and have even come back to normal growth curves. But, it's impossible in patients, can't really, you're not biopsying growth plates. It's impossible to make good correlations with the histology in the growth plate. So something to be, I'd say still something, and I've been in touch with some endocrinologists, something to be considered thoughtfully and cautiously in moderately severe OI, and perhaps a trial treatment undertaken to see what the response is. But there's certainly, if the child is not showing a good response in terms of an increase in linear growth, and you keep giving the growth hormone, then you're at risk of making things worse, because then you may just be increasing the high turnover. So it has to be done cautiously.
I agree with Dr. Marini, and I think so. If again the questioner is talking about like specifically about growth hormone to increase height in OI, I think actually Dr. Rauch and his son looking at X-rays and growth patterns in individuals with OI, I think found evidence that was supportive that the growth issue, there are growth issues that are not related to just kind of scoliosis or recurrent fractures in OI, that there probably seems to be, as Dr. Marini was mentioning, some underlying abnormal bone growth overall in OI, irrespective of fractures, that is leading to the short stature. And that would probably, again, not typically be very responsive to growth hormone therapy.
Right. I might add more for the OI aficionados, but some parents may know about this too, that usually we associate, this has been one of kind of the mysteries in OI, hasn't it? Because we usually associate short stature with chondrodystrophies and not as much with osteodystrophies. And a few of the types of OI, specifically 7 and 8, where the 3-hydroxylation complex is clearly expressed in cartilage as well as in bone, are correctly viewed as osteochondrodystrophies, bone and cartilage dysplasias. And I think that this is an unexplored aspect of classical OI, with its short stature. As you said, it's not just the fractures, it's not just the scoliosis. There's something intrinsic, and how much of it is in the growth plate or the transition between the growth plate and bone, I think really remains to be demonstrated.
Great, thank you. So someone is asking, and I think this will be the last audience question for today, because it looks like we are getting through all of them, which I'm very happy about. Someone just asked, can you discuss the risks of ports if children get IV bisphosphonates? And are there any kind of considerations there for children getting ports for IVs?
The main risk of a port is getting a blood infection. So the kind of when you access the port, you're kind of really very directly kind of, from going through the skin right into the deep part of the bloodstream that has a significant risk of sepsis, which is a serious blood infection. I would say that we generally are able to manage like all of our most all of our OI patients just with peripheral IVs. And there are things that hospitals can do, whether that's a bright light to find veins or using ultrasound to find veins or other sorts of things. And so we try to avoid portacaths as much as possible, and typically are pretty successful at that again, but it does take, nurses or other healthcare professionals who are willing to kind of put in the time to be careful and deliberate about starting an IV.
Great, thank you.
I'll give a little bit different perspective, because I know we have quite a few patients who have ports, and we make that an individual decision between the patient and the family. Some families, like Dr. Ayers talked about, the anxiety associated with getting a peripheral IV, especially if you've had a fracture sustained while getting an IV placed, is pretty traumatic. And so some kids or parents choose to do a port. Again, the infection is the concern. Fortunately, they're rare, but when they happen, they can be pretty devastating if you get an infection. And then the other part of having a port in a lot of our patients is that it gives them, especially if they live in a more rural community, or they don't have close access to a children's hospital, it gives them the opportunity to potentially even do infusions at home with home nursing. And so some families choose that as well. So I think there's obviously pros and cons to both.
Great, thank you. I'm going to put into the Zoom right now. We have a quick poll, and this is the last question is from the OIF to our attendees in this session right now. We want to know, so we're using language interpretation for the first time. We'd like to know how many of you used what. Also, on this note, I want to thank all of our speakers and panelists today. So Dr. Rausch, Dr. Franzone, Dr. Ayers, Dr. Marini, Dr. Sutton, Dr. Cheney, Dr. Wallace. I hope I'm not missing anyone. Thank you. Also Jacinta as well. And finally, Shriners Hospital for Children in Montreal, Canada. Thank you all so much for attending. If you have any questions, please remember you can email the OI Foundation at bonelink@oif.org, and we will answer you as soon as we can. I want to thank you all for attending today. And again, if you have any other questions, feel free to email us. And thank you again to everyone. Have a good day.